game-changing discussions on the big ideas that shape our thinking. This is One2One.
Dr. Hammed Ninalowo is a distinguished diagnostic and interventional radiologist whose pioneering work spans the frontiers of clinical innovation, leadership, and community impact. His professional journey bridges the United States, West Africa, and the wider global medical community, from advanced image-guided interventions on the brain and vital organs to building clinical systems that expand access for underserved populations. Hammed Ninalowo, welcome to One2One.
Very good. Thank you for having me.
Thank you for joining us. So help me understand, who is Hammed Ninalowo and what precisely is interventional radiology?
All right. So who is Hammed Ninalowo? So I'm a kid from Lagos who, I grew up here. I left to America at 16 years old. I did all of my secondary education there. I went to medical school and practiced in America. And, I got a passion for this field called vascular and interventional radiology. And the reason I kind of owned into this field at that time was this was something that was not available in Nigeria. And a lot of the things I saw doctors doing with minimally invasive skills, saving lives with technology was just not available in Nigeria. So I really keyed into this field of medicine because I knew I was going to come back to Nigeria to practice medicine, right? So after I finished, I stayed in America for about 4 years and was a consultant, and then started offering services in Nigeria. And I started coming back here 1 week every 6 weeks. And I remember when I started coming back here, no one knew what I did, right? You were talking about this field of medicine that no one knew what you could do, what the possibilities were. But if you look at interventional radiology, it's a field of medicine where in America, I just left America last week because I still go back to America to do some locum work, maybe once every 3 months for 1 week. And I realized how busy I was for that 1 week. All the interventions we were doing, emergencies, people with pulmonary embolism, strokes coming into the hospital, and we were able to intervene on these patients. But imagine no one was able to do that in Nigeria, right? So, there was no question that this was something that was needed. So after a year of going back and forth, I made a decision with my wife that we were going to move primarily to Nigeria, and we made that move in 2019. And, it was probably the craziest thing because everyone was like, this young guy, why are you going to Nigeria? You're at the peak of your career and you want to go do this thing in Nigeria. But, being in Nigeria made me happy. There was no question about that. And then being able to, do something new and trailblaze in something that was not available made me happy. So what is this thing called interventional radiology? And the way I describe it for people is basically we use image-guided techniques to basically diagnose and treat diseases. And some of the simplest examples I give to people are, for example, brain aneurysms, right? So if you have a brain aneurysm that is ruptured, which is an abnormal vessel in your brain that ruptures, and you could have this severe headache and go into a coma. In this situation in Nigeria before, the only treatment you could get was a neurosurgeon basically removing your skull and going to find that brain aneurysm to clip it. But as you could imagine, these are patients that are already very sick, right? But there's been this technology that's been around for over 20 years called brain aneurysm coiling, where we could go into an artery in the wrist or an artery in the groin and put in a catheter using x-rays to guide us to find that aneurysm in the brain and coil it without having to put the patient through the trauma of surgery. And these are interventions that replace surgery or augment surgery in a lot of different situations. In some situations, interventional radiology is the only field that can help a patient. So you could imagine this field not being available in Nigeria at all. So it was a pretty easy decision for me to move here in 2019. And I still maintain my practice in America at about 25%. And then COVID came and the question was, do I go back or do I stay here? And I made the crazy decision to stay here. But quite honestly, that decision has probably been the best decision I've ever made because it showed me how resilient I could be or our practice could be in staying here, surviving through that period. And we've just blossomed since then, as you said. And now we offer so many different services in our primary center and in multiple hospitals, emergent interventions to patients, and our service is now critical to healthcare in Nigeria and Lagos State.
You've talked about what drew you to this specialty, but I'd like you to bring it home now. You've talked about your experiences in America. So what do you feel is the strategic importance of this specialty to Nigerian and African healthcare going on to 2026?
Yeah, so, I must say, every week that I'm here, I am reminded of why it is important for me to be here and why this specialty is so important. Because every week I do an intervention on a patient that I know that if I am not here available physically and this field is not available physically, that patient will not survive, right? And I'll give you a simple example, right? We had a patient, 44-year-old woman who ruptured a brain aneurysm in Abuja. This was last month. And I'd ruptured a brain aneurysm for about 3 weeks, survived the first rupture. I'd been seen by a neurosurgeon, and the neurosurgeons basically told her there were no surgical options, right? The only treatment you had was endovascular options for treatment of this brain aneurysm. And I had a consultation with that patient. She called me on Saturday, by Saturday afternoon, because every brain aneurysm is basically an emergency. We had a consultation on Saturday afternoon with her and her family, and I told her very clearly, you have 2 brain aneurysms, probably the most complex brain aneurysms we'd ever encountered in Nigeria. If you do not get treated as soon as possible, you will rupture again and you will die. And I was very clear on the phone. Sunday morning, they get on a plane and they're flying to Lagos. 20 minutes into the flight, she ruptures in the plane. So the plane turns back to Abuja, right? Because obviously they can't keep flying to Lagos, 40-minute flight, and there are other passengers in the plane, and this woman is basically comatose on the plane, so they take her back to Abuja. Then I get a call from the patient's husband that Sunday morning and said, my wife is just ruptured in a plane. What do we do now? And this is a disease we've never treated in Abuja. We didn't have the capabilities or the team or the hospital or anything to treat in Abuja. So now I'm actually frozen for about 5 minutes as to what do we do. So I start making some phone calls to some of my partners in London, the gentleman that does neurointensive care for us in Owerri. They were very clear to me. They say, if you do not find a way to treat this lady in Abuja, she will die. There's no question about it. So we took a team of 5 people from Lagos, and we took that team of 5 people from Lagos to Abuja to treat this woman. And again, there was no doubt this was the most complex brain aneurysm case we had ever done. By the time we got in, she had basically occluded the internal carotid artery, which is the artery that carries blood to the brain. So that's the first thing we had to deal with. And then about 4.5 hours later, we were able to coil both aneurysms. And 3 days later, this lady is extubated. 3 weeks later, she gets out of the hospital and now she's jogging, right? And to me, I could be in America, doing procedure after procedure after procedure, but I could be here kind of moving mountains and doing things that people thought were impossible. And that's what drives me every day. What else can I do that everyone thinks is impossible, but we could make possible? And we just get all the resources together. And some of these things are crazy because some of my international colleagues see some of the work we do here and they just go, you have no backup. So what's going to happen to the patients, right? We have to do something. And, knock on wood, we've been very, very successful at a lot of complex interventions we've offered in this country. And we keep making progress every day.
So, Hamid, that's deeply, deeply insightful. In one fell swoop, you have just described the precarious state of our healthcare system, the distribution of services that are available. You had to pack up from Lagos to go to Abuja. You've talked about the resources you actually need to deliver the service. But you've also talked about patients who, but for your service, would almost certainly die. And there's only one, Hammed, maybe another one now in the works. But this is, of course, a very expensive service you're talking about. There's only one of you. What does that say about the precarious state of our healthcare system and the the sorts of diseases that are emerging and the urgent need to democratize and perhaps fund healthcare in this country?
No, so one thing I always tell my friends in Nigeria is that healthcare in Nigeria is about having a healthcare network. And what does that mean, right? You could have a problem and you could go to any hospital in Nigeria. And if that hospital does not have the resources or does not know the right person to call, then you will still do poorly. And that shouldn't happen, right? Sure. The healthcare in Nigeria is still very, very, very disorganized and broken. And as you said, the kind of services we provide, it's not a lie. The technology we use for most of our cases is very expensive technology, right? And until we are able to scale the program in a significant way where we could reach millions of people, it's still going to remain very expensive. And if you look at countries like India, what did they do, right? So Cook Medical, which is one of the biggest manufacturers in our field, has a factory in India, right? Jubei Medical has a factory in India. I'll give you an example. There's something called Lipiodol. We use it for basically treating liver cancer. It's an oil, comes in a 10 cc vial bottle. Lipiodol in India costs about $150. Same thing in Egypt. In America, it costs $1,200, $1,200. That's 10 times the price.
Of course.
Right? And how are they able to get it so cheap in India and Egypt? It's because the government has intervened. The government has made sure that these companies are bringing factories to their countries. The government has basically bulk purchased from these companies and guaranteed that they will purchase these products, right? So we are making a lot of progress in the private setting in Nigeria, but it's all progress in very little silos, right? And you still need that network to be able to access proper care. But as far as the large scale in Nigeria, we're still nowhere near we should be.
Of course, it's a postcode lottery.
Absolutely,
still is, and perhaps services like yours remain. I mean, to be absolutely frank, between you and me, the exclusive preserve of the wealthy and the untouched.
Yeah, I would say though, we do have a foundation called the iROCK Foundation.
Tell me about it.
And we've done a lot of work with our foundation. And our foundation, basically, our tenet is, if you have an emergent disease, especially a vascular condition, and you're a young person, and that vascular condition will kill you, and the only service in Nigeria that can treat you is our service, we will treat you. And we would treat you through our foundation, right? And we've done that over and over and over again. We don't advertise this significantly.
Well, you have now.
Because we're not the government, right? But we also have to be careful because we're a small private practice and we don't have the capacity to basically then have a lot of financial burden coming on us, right? But we've done this over and over. We have doctors that have referred patients to us from public hospitals all the time for specific conditions that the patients can't afford, and we take care of.
So, Hammed, we're really talking about specialty here, interventional radiology, that lends itself quite well to the use of technology. So I'm thinking about AI and this AI revolution. How has it impacted or contributed to the work that you do? And what excites you most, really, about what's happening in this field and what is to come?
So good. So as you said, interventional radiology is very, very technology dependent. And I'm an interventional radiologist, but I'm also a diagnostic radiologist, which means I can read X-rays, CT scans, and MRI. And in diagnostic radiology, basically, I've seen AI as an augmentation tool. I have not seen. A lot of people have said, "Oh, AI would replace doctors." I say, well, it's a bit hard for an AI company to say I will take the liability of reading a CT scan. Right? They would not do that. Well, at least not yet. So it's become an augmentation tool. Basically helps you find things easier, helps you locate things easier so that your eyes could go to the right place. And if you miss something, AI could say, hey, did you look at this area? And that's how we use it in diagnostic radiology. In interventional radiology, we use it as a tool basically to map out things currently. And in clinic, interestingly, AI, ChatGPT has been my best friend.
Yeah, me too.
I could look at treatment algorithms. I could look at, different things that I would normally go find in a textbook or find in an article. I just put in ChatGPT now. It gives me a complete algorithm of what exactly I should use for each scenario. And I just have to modify it, right? So it's basically, I think it's really an augmentation tool. It's made us faster in a lot of things we do, especially with research. But do I think it's going to completely replace what we do? No. There are things that are coming out like robotics, right? As you know, robotic surgery is already in Nigeria, right? And with robotic surgery, you could basically be in China and basically do a robotic surgery on a patient in Nigeria because you just need someone, controlling this from far away and good network, right? And that's also happening in interventional radiology. In the States, for example. So as you know, stroke, when a person has a stroke, and a person has something called a large vesicle occlusion where a vessel in the brain is blocked. If you go in and remove that clot, that person could do much better. It could be a person who's come in completely paralyzed to be a person being able to go home the next day or a day after completely normal, right? And the difference in that is being able to do something called thrombectomy, mechanical thrombectomy, where you go in and remove the clot. But as you could imagine, you can't have a doctor in every hospital being able to do mechanical thrombectomy. But what you could have is have a robot that's in every hospital and doctors at different stations where a patient comes in with a stroke, you put that patient on the table, the doctor then controls a robot from a remote location to treat that patient, and that's already happening. And the AI is a very, very big augmentation tool for that.
Yes, okay, well, thank you. So you worked across various systems, geographies, and models of care. I'm interested in what you think about what the biggest structural gaps in healthcare delivery today are. Perhaps limit your answer to Nigeria and speak a bit about Africa.
Yeah, so I think in Nigeria, I think one of the biggest things, one of the biggest problems is that we do not focus on centers of excellence. So if you go to most different countries now, you would see that, so the University of Pennsylvania is known to be a center of excellence for cardiac surgery. This is just an example. The University of Miami is known to be a center of excellence for oncology or something, right? And every hospital has something they are known for. In Nigeria, there's not a lot of hospitals that have something they're known for, right? Everyone wants to do everything, right? So you have the silos of cardiac surgery programs in every very different, a lot of different hospitals. And a lot of these different hospitals don't have all of the parts that you need to have a good cardiac surgery program. It's not just about doing the surgery and the surgeon doing the surgery. It's about the ICU care after. It's about the nurse who understands how to take care of a cardiac surgery patient, and having all of these parameters in place will keep a patient safe.
Sure.
And it is very difficult, especially in a country like ours, to have all these parameters in one place. Why? Because the level of attrition in this country is crazy, right? Most of the nurses, you used to work at one of the healthcare institutions here. Most of the nurses that you hired, how many years on average did they spend in your institution? Probably 2 years on average, right?
Less.
Or less, right? And they fly to England, and you spend time training them.
Yeah.
You spend time depending on them, and then they're gone.
Yeah.
And then one part of your equation is already gone in that cardiac surgery program. And this happens over and over. So I think where we need to move towards in Nigeria is developing these centers of excellence, where we identify centers where, for example, cardiac surgery is done very well. They have all of the parameters. Let's support them and send patients for cardiac surgery to that center, right? Make them very busy. It would also help with training, right? One of the biggest problems we have in training is the low level of cases that are being done in each university, right? We need centers of excellence so that training can happen in these centers. They're seeing a high level of complications. They're seeing a high level of cases when they come out. You do not want a trainee to come out of a training program and I've done 10 surgeries in a year, 10 surgeries in 2 years. And this happens in Nigeria, right? You have doctors that actually come out of training programs that have never done a surgery, right? And they're being hired at hospitals, right? But if you have centers of excellence, it would completely change our landscape.
Absolutely. And the principle of having centers of excellence is quite common sense, isn't it? But the fact is actually that, and this perhaps speaks to the way that our healthcare system has progressed, or perhaps regressed over the years. In the late 80s and 90s, the University of Nigeria Teaching Hospital was the National Center of Excellence for Cardiothoracic Surgery. The Professor Odeku, Dr. Ayaji, came out of there. But of course, the situation as you describe it is what obtains today. So I'm going to ask you to broaden out that point. What does that say about where we are now? Not just in terms of centers of excellence, but how the healthcare system has regressed and what we need to do actually beyond centers of excellence to get things back on track.
So, I still say that the truth of the matter is we have to recognize that Nigeria is still a very poor country. I think about 1% of the population controls basically over 99% of the wealth in this country, right? And, when you still have a problem where there's still no money going into the insurance companies, right? There's still no money going into healthcare. It's very difficult to scale healthcare, right? But even with all of that difficulty at the Ministry of Health, there still can be a lot of sensors and data being gathered as to what is being done at each university, who is where, right? Who are the people that are doing specific types of work, and leaning on that expertise to then help scale healthcare in our country, right? So I said before that most of the advancements in healthcare in Nigeria currently are being done by private entities or individuals, right? A lot of these private entities or individuals have come from abroad.
Yeah.
And they're already doing stuff in Nigeria, right? If the Ministry of Health or somebody in government wants to talk to a diasporan doctor today, where do you think they go to? They go abroad.
They go abroad, yeah.
Right? They go abroad to talk to our colleagues that are not working in Nigeria.
Correct.
Do not understand healthcare in Nigeria, don't understand Nigerian patients. I'm sorry, but they really don't.
No context.
The only people who understand healthcare in Nigeria are people that already practice healthcare in Nigeria.
Absolutely.
So essentially, right, I think there needs to be a lot of data being gathered on who's doing what in Nigeria, who can we lean on to advance specific specialties in medicine. And again, going back to those centers of excellence, leaning on those centers of excellence, and a lot of collaboration between public and private institutions, right? Letting public hospital doctors come into the private settings, letting private hospital doctors go into the public settings so that we can basically cross-coordinate and teach and collaborate to make patients better.
Absolutely. And you're quite right about that. And the truth is that the majority of the progress that's been made has been made in the private sector. Somehow we're hoping that will be reverse engineered into the public sector, as if by magic. Somehow. So I think we agree, of course, the importance of your doctor to know who to send you to, but there's a system interconnectedness that needs to exist within primary and secondary care itself in order to make good sense of the tertiary care service. Given the realities and the crucial nature of what we're discussing, how would you advise, what would you say that African health systems should do about allocating capital and finance to healthcare vis-a-vis the other needy parts of the economy?
Yeah. So, I mean, there is no doubt that our allocation to healthcare in Nigeria is still very small, right? But I think there's still quite a few, not so good decisions being made by healthcare investors in Nigeria. And I'll give you a very small example. A cath lab.
Put my drink down there.
Carry on, please. All right. A cath lab is a place where we do cardiac catheterization procedures. Also the place where I do most of my procedures, right? So if you look at a cath lab costs on average between $1.2 to $1.5 million to put together.
Correct.
How many of those machines do you think are in Lagos today? Probably about 8.
Yeah.
8 of them or so?
Roughly.
What do you think the
Just Lagos
utilization is for the 8 in Lagos currently?
Over 5%.
Less than 5%.
Absolutely.
Right. And guess what? The next hospital that's built in Lagos, guess the first thing they're going to buy?
Cath lab.
Cath lab. Why? Because it's fancy. You got to have it, right? It's shining, it's status. It's status, right? And this is the mistake we continue to make, which goes back to focusing on centers of excellence and collaborating, right? Why do we have to have a cath lab in every hospital? Why that $1.5 million could be going to something else that could help patients or help the healthcare economy as a whole, right? Why do we have machines that are that expensive just sitting around, right? And this again goes to the fact that we are not collaborating, right? And these decisions, and I just gave you one example. This decision, I mean, you could go to hospital after hospital. There's something called the bypass machine for cardiac surgery. I'm sure you know that machine. Go to a lot of these hospitals, they have the machine. Just sitting there, $500,000. Just sitting there. How many cardiac surgeries are they doing?
Zilch.
But they're buying these things because it's fancy, because a contractor has come in and said, this is all you need when you want to build a hospital. And some of the problems is also, we are not talking to the end users, the doctors that are going to use these machines when they eventually get bought, right? There's a hospital I offer services in, and I cannot do procedures for lower extremities at that hospital, right? And they paid a lot of money for their cath lab. Why? Because of the design, right? They had a consultant help them with getting that cath lab, but did they talk to an end user? No. right? And this, again, is a problem I've seen over and over and over. When you have this healthcare, these big grand plans in place, you have to have end users, doctors that already do a lot of these procedures, talk to them, pay them if you have to, and get their advice so that things can be done right. But again, it still goes back to making sure that we're consolidating and we're collaborating so that we're not wasting money as a people.
It's interesting. The irony is stark. You talked about the fact that, we're a relatively poor country. The level of healthcare and the robustness in the system is as we know it. But worldwide, only about 50% of people have access to an MRI scan. We probably have, in this country, perhaps in Lagos alone, a higher, much more favorable percentage of, scanners to individuals. We have cath labs all over the place. So we're not making the right decisions. That is true. So Hammed, there are, of course, moral and ethical implications to my next question. So think very carefully. I'd like to ask you, what was the most meaningful thank you you've ever received from a patient? I'm talking about your sense of fulfillment here.
Actually, this happened maybe last year. I was at the University of Ilorin giving a lecture. And after my lecture, a lot of medical students got up and asked questions. And then a family member of one of my patients got up and started crying. Right. And why did she do that? This patient, our mom had a brain aneurysm about 3 months earlier. And I remember they were looking for treatment. And I got on a virtual call with them. Right. And after the consultation, they were very clear. They said, Doc, we know your expertise, we know your work. Our mom has a brain aneurysm, but there's no way we could possibly afford what we know it would cost to treat this brain aneurysm, because we know that this is very high technology that would be quite expensive. But they said at that time, they had probably about 30% of what it would cost to treat their mom. And they said, we're willing to sell our houses, we're willing to sell our cars, we're willing to do anything to get this treatment done for our mom. And that touched me, because they didn't ask me up front and say, can we get this for free? What they said was, we understand how expensive this is. We need some help, but we're willing to make the sacrifices to take care of our mom. And what did I do? I said, don't sell anything.
Yeah.
What do you guys have? They told us what they had. We said, we'll cover the rest with our foundation. We'll take care of your mom. Yeah. They came to Lagos. We treated the brain aneurysm. She did well. They came. They then went back to Ilorin. And then I went to give that lecture, and then she got up in the audience and started crying, right? And she told a story of how I had taken care of her mom. And, a thank you in that way, it's just, it just touches you in the deepest level, right? Because you've taken care of this patient. I've forgotten I'd taken care of this patient. I'd moved on, right? And then she shows up in a crowd somewhere just to say thank you. And she drove to the university that day because she heard I was giving a lecture. She wasn't a student of that university anymore, right? She drove there to say thank you and to tell her story. Mm. And we have the stories over and over of people we've taken care of, and they say thank you in a lot of different ways.
Yes.
And those thank yous always mean a lot.
Yeah. Hammed Ninalowo, thank you for joining us on One2One.
Thank you very much.
Thank you.
Appreciate it.